Hello. Dengar tak? Tak itu. Oh, belah kanan. Hello. Saya dengar you betul lah.
Okay, if I put through, now you speak. Di sini ada seorang. Nanti Azri will pass over. Some simple, some.
Hello.
Bilang.
Hey, got any voice from there? Hello. Hello.
Ada ah?
Hello.
Tapi you can hear me kan?
I can hear you.
But
Your voice cannot hear, right?
My voice cannot hear.
Hey,
Hello.
can you what slide a bit inside ke? Dia tak you run the slide?
I run the slide for you. I need
tekan unmute je.
Bukan start video kan?
Tak, video tak. Sepatutnya kena tapi tak apa. Betul. Especially ICU. ICU intensivity.
Can you hear me?
Lagi? Belum. Adalah.
Bukan orang dah.
Dia tak pergi keluar masuk.
Okay, Assalamualaikum, a very good morning. So we will start our CME. So the CME for today is approach to depressed and suicidal patient. Okay. Tapi tak jalan. Okay. Alright, as an introduction, more than 7,000 people die every year due to suicide. This is like one death in every 45 seconds. The suicide occurs throughout the lifespan, and in 2019, WHO global report as suicide is the fourth leading cause of death among 15 to 19 years old. History of suicide attempt is the strongest single risk factor for suicide. And regarding the psychiatric condition associated with suicide risk, MBD is the commonest psychiatric condition associated with suicide risk, followed by schizophrenia, personality disorder, bipolar disorder, and subsequently PTSD. Regarding the commonest method of suicide, injection is the most commonest suicide because suicide usually happen in low or middle income countries. That's why injection of pesticide is the commonest method, followed by hanging and also the firearms. Okay, looking at the Malaysia situation, the suicide rate in Malaysia is between 6 to 8 per 100,000 population per year, and the trend is in rising. It was found that suicide mainly involves the age group ranging from 24 to 44 years of age. Okay, regarding the prevalence of MBD in Malaysia, it is between 8 to 12%, and the risk of suicide among hospitalized patients with severe MBD can be as high as 15%. That's why there's a strong link between MBD and also suicidal risk lah. Okay, a bit on depression. As we know, during our medical school, during our psychiatric posting, we usually use the DSM-5 to diagnose MBD. So to diagnose MBD, it can be we can diagnose MBD using either DSM-5 or ICD-10, but I think we commonly use DSM-5. There are 5 criteria that need to be met to diagnose MBD. The criterion a minimum of 5 symptoms. A minimum of 5 symptoms is required, which the symptom must last most of the day, nearly every day for a minimum of 2 weeks, and one of the symptoms must either depressed mood or loss of interest or pleasure. So this is the short, table 1 is the summary of the diagnostic criteria for the MBD symptoms. So it must fulfill 5 out of 9 criteria, and one of the criteria must have either depressed mood or loss of interest or pleasure. And the symptom cause significantly, clinically significant distress or impairment in social, occupational, or other important areas of functioning. The exclusion criteria for diagnosis MBD: first, if there is a history of symptom use or medical condition, or there's a history of psychotic disorder, or there is history of manic episodes. Okay, if a patient has criterion C, D, or E, so the MBD of criteria, the diagnosis of MBD cannot be met. For the risk factor of MBD, first is female, young age or older age, especially people in nursing facility, unmarried or divorced or widowed, major life events such as recent death or recent breakup, poor social support or socially isolated, substance abuse, pregnant or postpartum period, multiple vague symptoms, sleep disturbance, loss of interest in sexual activity, chronic illness or pain, and also obesity. So who should be screened for depression? Ideally, in our CPG MBD, ideally all adults should be screened for depression. But it is unlikely to screen all the patients for depression. So if patient have this kind of risk factor, so we might need to dig further regarding depression symptoms. There's a few screening tools used in Malaysia for screening of depression. Usually DAS, PHQ-9, BDI, HARTS, and Hoody's question. But I think the most commonly one used in ED setting, we can use DAS or PHQ-9 lah. Okay, there's a 2 question regarding Hoody questions. It's a shorter tool which has been validated locally. It consists of 2 questions, which is the question comprised of the symptoms of the 2 important symptoms of the MBD. So which is the depressed or hopelessness, and also loss of interest or pleasure. All right. Okay, there's a pathway of assessing depression in ED. That can be used in ED. First, the patient may express or come with MDD punya symptoms. So after that, we assess for any suicidal ideation. Review all the medical history and or secondary causes that may cause depression. If the patient have expressed suicidal ideation, if yes, so we need to get further history regarding the suicidal plan or suicidal ideation, right? If the patient does not have any suicidal ideation, conduct a complete thorough physical examination and also obtain diagnostic studies if needed. After that, if there is any sign of secondary cause of depression, if yes, so we need to have further workup to rule out any other cause of depression symptoms. If no other cause of secondary causes, so we can use the PHQ-9 and look at the score. If the score is less than 15, we might consider to discharge the patient by give a psychiatric referral as outpatient. If the score is more than 15, it suggests of major depressive episode, and patient might need inpatient referral to the psychiatric, depending on patient situation as well. This one is not from CPG. This one I took from there's a literature review regarding depression pathway in ED. Tapi this one is not inside the CPG lah. But I think it can be implemented in ED because it's quite straightforward, and sebenarnya this is what we do all the time in ED if we met with this patient. Okay. Regarding the suicidal thoughts and behavior frequently, we can see suicidal thoughts and behavior among the depressed patient. So initial detection of depressive symptom warrant a true consideration of the patient's suicide risk. So any patient come with depressive symptom, we must evaluate for the suicidal risk. Okay, a few terminology regarding the suicide. First, we have according to American Psychiatric Association, suicidal ideation is a thought or serving as the agent of the one's own death, or basically is a desire for someone to kill him or herself lah. And then suicidal intent is a subjective expectation and desire for a self-destructing act to end in death. Okay, suicidal attempt is defined as self-injurious behavior with a non-fatal outcome accompanied by evidence, whether explicit or implicit. Maksudnya sama ada clearly or tersurat or tersirat that the person intended to die. Basically, it features some consideration on how or when or where the person may kill himself lah. Near miss suicide attempt is potentially self-injurious behavior with evidence that the person intended to die but stopped halfway before physical damage is occurred. Suicide death is basically self-inflicted death with evidence that the person intended to die. Non-suicidal self-injury is a direct, deliberate destruction of one's body tissue without any intent to die. For example, scratching his skin or burning his skin, right? And inpatient suicide is a suicide committed by a medically ill patient who is hospitalized, or basically is a suicide within the hospital premises. Okay, regarding about the risk factor of suicide, I think this one is the one yang I need to emphasize to all of us. We need to recognize the risk factor for suicide. So there's an individual risk factor, symptoms risk factor, and also current personal risk factor. For individual risk factor, usually suicide male, age between 15 to 35 years old, or extreme age more than 65 years old. Previous suicide attempt, as I mentioned before, previous suicide attempt is the single most strongest risk factor for a person to commit suicide. Any family history of suicide, chronic pain, illness or disability, psychiatric illness such as MBD, schizophrenia, history of sexual or physical abuse or neglect, people in prison or police custody, people with sexual identity conflicts such as lesbian, gay, bisexual, vagabond, post-social support or social isolation, environmental here means if the patient or the person has some financial issue, live in impoverished surrounding. Okay, about the risk factor of symptom, basically is a mental state, acute risk of mental state punya symptoms lah, depressive symptoms, psychosis, any anxiety or agitation, panic attack, anger, impulsivity or chronic insomnia. Sorry. Okay, current personal risk factor is the acute risk factor that patient might have to commit suicide. at-risk mental status, which is depression, schizophrenia, recent interpersonal crisis, recent suicide attempt, recent major loss, trauma or anniversary, alcohol intoxication, any in drug withdrawal state, chronic pain or illness, financial issue and appointment, any issue with family state, family affair or any such as child custody issue, unwillingness to help to accept help, cultural or religious conflict, and difficulty in accessing help, especially for foreigner that came to, especially for foreigner because they have to pay in order to access the healthcare punya service. Okay, beside risk factor, we have what we call protective factor, which is the protective factor means characteristic that make it less likely for the individual to consider or attempt or die by suicide lah. It can be internal factor or external factor. Especially in for internal factor, for example, if patient has good coping and problem solving skill, positive value and belief, ability to seek and access for help, spirituality, capacity for relative testing, reasonable frustration, hopefulness, fear of suicide, and sense of responsibility. So this is internal factor that may protect the patient from commit suicide. For external factor, we have strong perceived social support connection. So that's why social support and family support is very important. Peer group affiliation, children or pets at home, religious prohibition, positive therapeutic relationship, sense of responsibility, receiving mental health care, and also fear of social disapproval. There's a few stages of suicide. First, the patient might have ideation, and then the person will threaten to kill himself. And after that, if there's no intervention taken at this level, patient might attempt. And if it's successful, patient will die lah. Okay, there's a few risk assessment tools that can be used to assess the suicide risk. I think the most commonly we use is modified SAT person. There's another assessment tool such as back suicide index scale, blah, blah, and seterusnya lah. So basically, modified SAT person scale is a point. So you can ask the patient, if the point of less than 6 is the low risk, intermediate risk about 6 to 8, and high risk is more than 8. What is the significance regarding the risk? If it's a low risk, we might consider to discharge the patient with outpatient psychiatric evaluation. Intermediate risk, we need to consider to hospitalize or at least very close follow-up. If it's a high risk, patient may need inpatient assessment lah. So basically, any patient with suicide ideation, I would ideally refer to psychiatric. It depends to psychiatric whether they want to discharge or not. Sometimes psychiatric will discharge, but they will give the earliest appointment. Okay, how to approach this kind of patient when they came to ED? First, as usual, we start with the history taking. We need to establish rapport. To establish a rapport, engage with the person, be respectful, be professional, and be empathic. Don't be judgmental. Don't be shocked or panic if patient addressed that he or she wanted to commit suicide. Don't try to cheer the patient by making jokes about his or her suicidal thoughts, and don't make the problem become trivial. After that, ask the general question first. For example, how do you feel at the moment? Is there anything troubling you lately? Do you feel that no one cares for you? Patient might give some response that indicates suicidal thought. For example, I just cannot take it anymore. I cannot do anything right. I wish I was dead. All my problems will end soon. There is no way out. Patient may not state clearly that he or she wanted to die, but there's some clue in her or his statement that indicate there's some sort of suicidal thoughts. Don't forget to rule out any medical condition that may cause patient to have that symptoms. Okay, here are some medical conditions associated with mood disorder symptom. So patient might come with depressive mood, but not all these depressive symptoms associated with MBD. So we need to rule out. Thank you. Okay, so we need to rule out other medical conditions associated with any mood disorder symptoms. Therefore, history is needed. Thorough history is needed to rule out or rule in any medical condition. So this is a list of potential medical causes that may manifest as mood disorder symptom. So we have endocrine disorder, central nervous system disorder, and the list goes on. Okay, so after you ask about general question and you can check the history that patient might want to commit suicide, assess for the suicide intention. You can ask the patient, okay, asking about suicide will not make the patient to become more suicidal. This is a wrong concept. So even though the patient doesn't have any suicide ideation, by asking them any suicide intention or ideation will not provoke them to have that idea. So assess for suicide intention. You can say that some patients with similar problems have thought, has expressed their feeling about ending their life. So how about you? Do you have any? When do you have this thought? How often do you have this thought? And the list goes on. So this is example of question that you can ask for patient to assess for suicide intention. After that, assess for suicide plan. Basically, you want to know how, when, and where the suicide, if the patient wants to commit suicide. Basically, you want to know how the patient wanted to take his life, when or where. For example, patient might plan the suicide by closing the door, ataupun has been accumulating toxic substance, and so on. So, if you guys doesn't remember anything from the presentation, the most important is you guys remember the red flags. Okay, these are some red flags that might indicate the patient have high risk of suicide to commit suicide. For example, often talking or writing about death, making comments about being hopeless, expression of having no reason for living or no sense of purpose of life, increased alcohol or drug misuse, withdrawal from friends, family, and community, reckless behavior. For example, driving recklessly, dramatic mood changes. For example, you know someone who is usually kind and suddenly become angry or aggressive, or someone who is being sad or struggling with depression suddenly became calm and seemingly happy at peace. So the dramatic mood changes might be a sign to commit suicide, high risk to commit suicide. Assessing any lethal means, talking about feeling trapped or being a burden to others. Okay, after you're done with the history taking, next we move to the physical examination. Similar with all patients that came to ED, we start with the general examination first. Then we do vital signs and cognitive assessment. Basically, this one is focuses to identify any medical condition. And next, we can assess behavioral mental health status assessment. This one focuses to identify the presence and degree of depression. Behavioral mental status assessment is the one that we learn during our psychiatric posting. For example, general appearance, orientation, speech, motor activity, and so on. This one will be elaborated further by Jocelyn later. Okay, do we need investigation for this kind of patient? It is needed if you want to rule in or throw out the medical condition. Okay, so not all patients that come with depressive symptoms we need to take back. Basically, NBCRP is our spinal reflex M. So, lab studies are not routinely indicated unless if you need to rule in or out medical condition, such as patient with advanced age, patient with medical comorbidities, or patient with a psychiatric presentation. For example, a young lady came with a psychotic, with the first onset of psychotic symptoms. You might need to consider to do CT brain as you need to rule any organic cause causing the psychotic symptoms. Okay, if the patient is known to be psychiatric patient, so as usual, do the full medical and psychiatric history, but you have to dig further regarding the psychiatric history, focus physical examination, and mental status examination. But I know in ED, we rarely do this mental status examination. Tak sempat nak tanya pasal benda susu tak sempat lah basically. Routine serum and urine toxicology screening is not recommended unless you suspect the patient took something, have any ingested any substance or any medication. And if the patient has no onset of psychiatric symptoms, consider to do additional tests, especially in elderly or in immunosuppressant patient or in any medical comorbidities. So basically, there's no if it's a depressive symptom, or so we do not have to send any investigation to diagnose patient with MBD and suicide. Okay, not much we can, in ED level, not much is more to supportive care in managing patient with depressed and suicide patient, because all the medication will be started by the psychiatric team. So what we can do in ED level, first, provide safety environment. What is considered as a safety environment is, we can, there's a system that we call suicide precaution ED. So first, patient might be placed preferably near nurse station and within view of staff. Avoid placing patient at the end of cubicle near exit or the window. Patient is restricted to his or her area and not permitted to use anything that may cause harm. Preferably to have one-to-one supervision, but I know this is hard to do in ED. So we can educate the company, the family members or relative to have this kind one-to-one supervision. Be especially alert or to potential dangerous items. So remove all the potentially dangerous items such as knife, scissors, nail clipper. Sometimes nail clipper also can be dangerous for this kind of patient. Check at frequent, regular interval to ensure safety. How frequent and regular you want to check, it depends. If a patient has just mild symptoms, maybe you can do 1 hourly or 2 hourly. If it's a really aggressive patient that you might need to do restraint, you might need to have regular checkup for this patient, like 15 minutes, initially 15 minutes, then hourly, and 2 hourly. Okay, observe and document patient's behavior and observe and document the patient's behavior, pattern, sleep, and interaction. Okay, so we can first provide safety environment. Second, we can do no suicide contract, or the other name is known as no harm contract. It's basically a verbal or written agreement between patient and clinician intended for patient to articulate that he will not attempt to hurt himself. So basically, we want patient to articulate that he will not hurt himself. But the efficacy is not that much. And usually this technique initially was used within the psychiatry team now. But the teacher said that the efficacy is less than 50%. Maksudnya tak boleh juga lah. Okay. After that, we can do little means counseling, meaning that we offer a brief counseling around suicidal patient to assess the little means. The clinician can ask the patient about the little means available to the patient, such as and provide options for restricting the access. For example, disposal of the poison substance. If patient have weapons at home, we might ask the patient or relative to lock up the weapons and give the key to the spouse, and so on. Okay, and then early refer to psychiatric clinic or counselor. Okay, this part is the list that we can do for patient. Sometimes when we refer to psychiatric team, they ask us to discharge the patient, but what we want is the earliest appointment from the psychiatric team. Okay, and from my experience here, the earliest I can give is the next day, which is okay lah, kan cepat dan cepat sehari. And sometimes they will see the patient, they will ask to send the patient to the clinic itself. So I think it's quite enough as long as we have the psychiatric input about this patient, because suicide risk, once the patient was discharged from the hospital, the patient might commit suicide at any time. Next, we can provide information to the patient regarding outside hospital resources, such as 24-hour crisis hotline. In Malaysia, the most active one is the Befrienders. There's a website about it, you can go up, and also Malaysian Mental Health Association. Okay, we can offer this kind of information to patients so that patient can know who to call if they patient know who to call if they have sort of problems. Okay, there's a risk stratification for this patient. Low risk suicide. The criteria is patient might have mild or basic suicide ideation, no history of suicide attempt, and a good social support. Patient appear cooperative, no agitation, not irritable but not aggressive, and coherent history. Okay, for this kind of patient, we have to apply the suicide caution, allow the accompanying patient to monitor while waiting patient to be reviewed by psychiatrist, for example. And even though it's a low risk patient, I would suggest to refer to psychiatry team as well. Let the psychiatry team decide whether to research or to admit this patient. For moderate risk patient, this patient has suicide ideation but haven't taken action yet. No other acute risk factor, history of psychiatric illness and receiving treatment. Patient might be agitated or restless. This intrusive behavior, bizarre or disordered behavior, confused, withdrawn, or ambivalence about the treatment. So this kind of patient, first we apply the safety measure. All right, remove all the dangerous item, suicide and absconding precaution, and also this one we refer to psychiatric team. Okay, for high risk patient, basically patient that serious or nearly lethal suicide attempt, persistent suicide ideation or latent ideation with intent and or planning, patient with psychotic symptom, recent onset of major psychiatric syndromes, or patient was recently discharged, any history of act of aggression or impulsivity. The patient might appear extremely agitated and restless, physically or verbally aggressive. So this patient might require restraint, and violent behavior might be observed for this patient juga lah. So this one patient memang we have to sama juga lah. Provide a safety environment for this patient. Urgent referral and rapid evaluation by the psychiatrist. This one is very important lah, because not much medication that you can give to the patient unless macam kalau yang patient tu within saraf benzodiazepine ke, and apply physical restraint if indicated for this patient lah. Okay, last but not least, depression is treatable and suicide is preventable. So I think with mental illness, one of the biggest barrier to prevent suicide is the stigma in our culture. This stigma prevents the patients from seeking help. So psychiatric diagnosis and being in ED, sometimes we don't have time to properly diagnose a patient. To properly diagnose the patient with psychiatric illness lah. So psychiatric diagnosis need to be thorough and extensive evaluation, which is feasible nor realistic in the ED. So I think in ED, what should we should the important thing is we should be able to assess and collect information on the presenting symptoms, recognize the risk factor, and pick up the red flags, and also necessary referral to the psychiatrist. I think that's the most important in ED level regarding when we approach to depressed suicide patient. Okay, this is my references. That's all. Okay, number 3, recognize the suicide risk. Okay, I will pass the mic to Jocelyn. Sharing has
Okay, so sorry, we don't have to go to this because she's is quite full. So any question about the depression and suicidal attempt in ED? Any question about it? Okay, then we proceed with our top-up CMD. So actually, depression and suicidal risk is quite important in the department. But because our Malaysian culture, we are quite didn't emphasize of the importance of psychiatric illness. But if you take a OC paper like FRChem, it's a compulsory every year question in the OSCE. We got one station for PSY. We have to plug the PSY, we have to do the examination on PSY. It's a compulsory station. So I think slowly our Malaysia will more emphasize of the importance of the PSY disease in Malaysia, especially in ED department. So it's very easy to do an examination in respiratory in a CBS examination. We are quite used to it. Not to say easy, but we're quite used to it. But how should we proceed with mental PSY illness. How should we examine the patient? There is a series of how we examine it. You see, we can do an isolation, we can do a percussion, we can do a palpation on this illness. But how about the psychiatric examination? So even the UK people have come out with QIP project. They have accumulated the studies within 2 years' time. Around 18,000 people come to the emergency department in UK, which is in the 183 of the ED. Only 24% have done a proper mental status examination. They otherwise are all referring, which is UK system is trying to emphasize all the PSY illness must do a mental status examination, regardless whether the patient is suicidal attempt, depression, mania, or ADHD, or the even pediatric, they also ask for it. Okay, so my guideline is from this book, Oxford Handbook Psychiatric edition 4. You guys can download on the internet, it's free. So a mental status examination is a summary of how we should do an examination on a psychiatric patient, and the evidence we got from the examination can support your diagnosis, and any of your evidence maybe can against your mental illness diagnosis, and you can record the current type and the severity of the disease without waiting for our dear PSY to come. So the first of all, you attend the patient, inspect, look from the far. How is the patient appearance? Is it hygiene or not hygiene? Can the person take care of her own self? Can the patient dress well or not? How is there any tattoo, IV video mark, or any other self-harm sign on the patient? Any jaundice? Is it a patient is an IVDU patient? And is there any abnormal involuntary movement? Is there a stiffness, rigidity, tremors, akathisia, or appear distracting? If the patient has possibly present with a tremor or stiffness or rigidity, possible is a side effect of PSY drug. And other than that, you have to think of the most severe issue, the medical illness or the medical pills overdose. The other one, you talk about the behavior, whether you have to comment the patient whether cooperative or not. Is it open, secretive, suspicious, or appeative? You have to see, you have to comment the patient whether have any eye contact, how is the facial expression, how is the engagement to the hallucination. Does the patient respond to the hallucination or not? Otherwise, you have to record all the psychomotor activity, abnormal movement, and mannerism. Speech. The most important is about the speech. Whether the patient has presence of a pressure speech, slow speech. How is the quantity of the speech? Is there any monotonal speech or tremulous speech? The volume of the speech, the frequency of the rhythm. It's important to document in that way to, in the depression, maybe it's slow, in the mania, maybe with pressure speech, and for pediatric, of course, with patient with ADHD, and will be present of echolalia. Echolalia has been whatever you say to the patient. How are you? The patient will answer, how are you? It's echolalia. You can very easily see in the ADHD psychiatric pediatric patient. Partylalia is also in ADHD pediatric patient. So you ask, how are you? You answer, you. How are you feeling okay today? Today. You answer like this. They will repeat the last word in your sentence. This is a partylalia. Neologism is the new word formed by the patient. They will create their own word without other people understanding. And then you can see in the schizophrenia and any psychiatric illness patient, but most of of them is a schizophrenia patient. Okay, so mood, as usual, mood just ask three simple questions. How's I feeling? How's your current mood? Are you feeling depressed, anxious, maybe? So for the mood part, you remember easily, euphoric, you apathic, anxious, or angry. Okay, beware of the mood and affect. Okay, mood is totally different compared to affect. Mood is the mood you present at the home. At the home, macam mana do you feel sad at home? Macam mana? Affect is moment to moment expression. When you club the patient gives you expression. Fluctuation that's in when you club the patient, interview the patient is always the same face, didn't change at all. Does it mean the effect is fixed? Or patient want to give some effect, that means the facial expression change. It will be restricted. The something is controlling the facial expression. And then the level effect is uncontrollable. The facial expression keep on changing throughout the whole interview. Okay? The intensity of effect, as well how frequent, how fast the change of effect will be. Very fast, is it blunted or flat? If blunted, most likely you can see the depression patient. High, you know, most probably you can see in the mania patient, and for the flat, is more on the schizophrenia patient. Okay? So congruency of effect and incongruence effect is, I give you an example. For example, this in the movie Joker. So Joker, whenever he tries to tell something sad, depressed, he will start to laugh. This is an incongruent effect. That means what he tells is sad thing. My father is passed away, my mother is having accident, but he's laughing. So that one we call incongruent effect. This is a psychiatric illness. Congruent effect is what you tell is steady with your face. The one we call congruent effect. Okay. So the effect and the mood is totally different. Effect is what you observe. Mood is what the patient tells you. Okay. So thought is more things to go deeper into it. So I have summarized into a simple diagram. So you access the thought. So when you morning wake up, the sunrise, the patient wake up, and then you eat the breakfast. So for the tangential thought, if you morning wake up, I go into the swimming pool straight away. So that's the tangential. It doesn't go to the breakfast. For the circumstantial thought, if you sun rising, or I wake up for the break, I go swimming straight away, I go shopping, or then I go breakfast in the end. So that's a circumstantial thought. But loosening of assertion of the thought, the patient will say, morning wake up, I dress well, and then I go work, I do this, I do that, but never will went to the normal pathway of thought. This one I think we will have to need more experience on how to access about thought process. Set of idea. So they will look at that, they will give you a thought that the morning wake up, and then suddenly you will say, oh, I'm going to work, then I go back to sleep, then I suddenly dress again, then I go wash the teeth. So the flight of thought, I think, should be no issue. For the word salad, I think when the pronunciation, the all things is mixed up together, you are not what that happened. So it's word salad. So otherwise, you have to ask about any thought insertion and thought withdrawal and thought was testing. Do you feel ever the patient, you ask the patient whether anyone put some idea in your brain? Do you think anyone can hear what you're thinking? And then any person remove your thought from your brain. So this is what you should ask for the patient. And then perception. Perception is, if you go deep into it, it's a very big topic, super big topic. So hallucination is divided to elementary, complex, auditory, visual, olfactory, and somatic. I think I have known to explain about the auditory. It's the hearing, visual is the seeing, olfactory is the smelling, somatic is the feeling of sensation. Okay, this one I don't need to explain. Elementary is something very simple. You see a flash of light. You see something of shadow, that's elementary. Complex, you see some home image. You see a human, you see some of the human animal that answer to you. That is called element. That is called complex theory. So element theory is a simple one. So reflex hallucination. What we call reflex hallucination. Okay, for example, a patient, he listens to music on a certain song, they will suddenly activate reflex hallucination. They will saw something. Whenever the song rings, they will saw something. That's called reflex hallucination. Hearing is the auditory, he hears something, but the see is produced visual hallucination. Okay, and then for the hypnagogic and hypnopompic is during sleeping and waking up. When you're sleeping, mama like that, then you saw something. When you wake up, mama like that, you saw something. It's called hypnagogic and hypnopompic hallucination. And otherwise, it's the extra campaign and Lilliputian. I think Lilliputian is everybody know is when you feel the yourself is small one, and at least in the wonderland, and you saw the surrounding is the big one. Okay, so for the extra complex hallucination, so actually you like what you see in the ghost movie, you always feel someone is behind you. You always sense that someone is standing here behind someone and looking at you. That is called extra complex hallucination. This hallucination will always happen when after you watch ghost movie. Okay. So otherwise, that is called depersonalization. You feel like you are living in the glass wall or bubble. You feel like you are totally not in the world that you are existent. You are seeing yourself in the glass of a wall. And the realization is what the patient feels the world is unreal. Okay, and this I think they can tell you more clearly that for the cognitive, otherwise cognitive is another topic. So actually cognitive is a lot of method of examination, but the most I only pick one which is called mini mental state examination. So actually assess the patient orientation with orientation whether how many years you are now, where are you now, what's the time now, and register. So actually you name 3 objects, for example, apple, penny, and ask the patient to repeat it. And then you see the patient, whether can repeat the word terbalik or not. For example, W-O-R-L-D and then become D-L-R-O-W. And then after that you go back, you recall the patient, whether the patient can remember the previously you show the 3 objects that you show them. And then language, you name 2 objects and then repeat it. So you go through it and then you get the scoring with the linear mental state examination, whether you go cognitive impairment or mild cognitive impairment or severe cognitive impairment. Sensitivity is about 30 to 60%, specificity is 92 to 100%. So the aim is actually to check their attention span and concentration level, and what is their short-term memory like, whether their orientation took place and time or not. The last one is very simple, is insight and judgment. So you ask the patient, do you know what you're having now? The insight. Do you understand what are you facing now? What is the medication you eat? So if the answer, I don't know, I have no illness at all, poor insight. Okay, recommend a poor insight. Okay, and the patient can answer you, I have this, depression, I'm eating this medication, SSRI, I'm eating this. Okay, this one is a good insight, and then you just document it. For the judgment, it's very easy. You just give a logic question. For example, one day if your house is on fire, what would you do? So if normal healthy patient, they will answer, oh, I will clean sky and pray, oh, my medical staff, or I call a firefighter, or I call for help. This. For a PSL patient, maybe they will answer, oh, I will laugh and then I will be happy. So the judgment is full in the PSL patient. So in conclusion, all what you should document in the ED note should be basic personal information, which is the name, age, and any medical illness, and psychiatric diagnosis, and the description of the presentation, whether patient come with hallucination, aggressive behavior, or any suicidal method, and then description of current symptoms, whether the patient has symptom worsening or the symptom is a new one, and then you only put on the positive figure of a mental status examination that I mentioned previously, you only put the positive part to support your diagnosis. And the last one you go for suicidal risk, and you go for the how you should manage the illness. Okay, this I think what we should improve in our PSY approach, PSY disease approach in ED. Thank you. Any question? Okay, if no question, I think any announcement to make? If no announcement, later we have 9:30, we have makan-makan, Chinese New Year makan-makan, organized by our Chinese friend. I think you guys can join us. I think you should join. Just want to say anything?
The presentation, we learned something, right? Especially how to assess mental status. I think some of this part over the years that we were already know so much. I'm not expecting you all examining and assessing so hard because like a psychiatry assessment, but at least you pick up and identify those high risk.
Kalau you all nak bagi something, apa approach?
There's a recipe and there's a person. So if the doesn't work, what's the next kind of treatment? You guys can use ketamine for severely ADHD. Benar tak? Yeah, so kalau benzo doesn't work, you can actually use, especially kalau patient at the insurance time, that's when they are quite active. Let's say 2,600. Kalau ada they go to 3.5 more into the that's when it's okay, so why is money giving ketamine in severely ADHD? Yes, actually boleh. Okay, kalau benzo doesn't work, the next one is ketamine.
Approaching, what's the experience? What is the biggest challenge approach the patient? It's not just educated about depression, but also about okay, the history. I think history is very challenging. Again, I mean, it looks nice, check the appearance, the effects, but it's quite difficult to tease out the history from the patient immediately. So I just by nature, us as emergency doctors tend to be rushing, and we just want to go to the next patient and tendency. Sometimes our effect also affects the patient and make the patient more depressed and angry. So I think that needs a different tone when you see this kind of patients and lots of patients. So something actually a bit more on the high adrenaline side have to might change your personalities. You can't change your personality, but you have to not agitate the patient more by aggravating the situation. So it's even more challenging now. I suppose the 90 we cannot ask pakai full PPE kan, when you approach them, so like be personalized with the so. But always, I think for me, my tips is make a good relationship means have open-ended questions. For them to trust you, they must feel like you trust them. So you must introduce yourself, who you are, so they know what is your role there, and you are not there. You are there to help them. Okay, so I mean that's probably a nice opening. Makes sense, tapi sometimes something that we forget. Masuk ni ingat mana ni doktor kan, but sometimes you know the doctor is the nurse, apa kan? Tak tahu perempuan kan lelaki pun kadang sudah berpikir kan. So and your tone and ask why you're here. They're usually out of not their own will to come to the hospital. So it takes a lot of experience to ask questions. So I think that's the biggest challenge of emergency doctor. We actually want to be faster.
If you know the patient has a left brain, do not approach the patient, do not try to move the left brain of the patient. Okay? Because remember safety first, it's your safety first. When you tahu bila tu dia do not approach, do not try to move it, create for this security. Okay? So it's your safety first.
So just want to take to highlight one is that I think if you all remember, in somewhere in August, there's one guy who accidentally fell from height in the hospital. Actually, when we retrospectively study back the case, and you know whether we did access or not, but not documented. There's no neurology, only UCS. This UCS is full, only that statement. But in the one that what I heard is the patient did have this suicidal ideation. That's why the reverse psychiatry. But our side we did not mention anything like that. So like when you get patient with disoriented, depressed, and all this stuff, because of the I'm not accept. I mean, probably assessment is sort of like or the party and outer sensory. I think we just have to access a little bit. Probably, if, let's say, we identify the time, maybe
it's not about the topic lah. Just want to ask, right? Recently, baru-baru kita dapat patients. The thing is, we noticed that few of the issues that is how to say, especially masuk ICU, already done gene expert already, but they wanted a PCR also. So that's why we don't know how is it like. The thing is the initial janji to and initial guideline plan to is not really followed up. So now it's like changing.
I think that part we noted, but the initial discussion, if I'm not mistaken, was not attended by intensivists. So it's mainly by other faculty and mainly ID. So yeah, that part probably we should have included them also before that. So for ICU admission, I think we need PCR. Let's follow the intensivist for now. Because we want those accidental admission, the ICU vaccination and the ICU shutdown.
Within this week, we start to speak up. Hopefully, by the end of the week, we will get decision from the ICU team that the use of the next PCR for validation. Hopefully, by the end of the week, we will be somewhat. For the time being, we want to look at the PCR.
case exposure to the ICU. That happens, they need to shut down the ICU entirely. There's no patients for, there's no other place for them to manage their patients. Any other issues with the patient environment?
Like let's say we are on the floor, let's say when we are working, you foresee like the cases are getting more solution, but they know it's getting to, then you inform the pakar, and then we will find place to open the emergency area, as Mother people sector. So if you on the floor, anything feel that the patients are coming in more, then that's all. No announcement, then okay, thank you for our presenter, and yeah, join the makan-makan after this.
几点？他在那里。
可是我努力吐，所以大概8点多左右。
8点几
8点半的时候我比较好努力。
很久了。